Section of discussion of diabetes in video, we'll touch on the acute complications of diabetes. And there are a few here. One that's not on this list, I need to update this list. I'll mention it in just a second. So number one, we've alluded to this already, is hypoglycemia. As I mentioned before, hypoglycemia is primarily a risk in these conditions because of the treatment for the condition. So all of the medications that are used in the management of diabetes have the potential for producing hypoglycemia. So it's critical to have that awareness because all of our diabetic patients are going to require some form of intervention. And the risk of that intervention is hypoglycemia, and hypoglycemia is highly lethal. Hypoglycemia is not complicated to treat, but there are some key strategic components to that treatment that help prevent a rapid spike of sugar and then an immediate drop again. So there's just a few nuances to that. Then DKA, diabetic ketoacidosis, is a severe hyperglycemic condition. So these patients have very high sugars, in excess of 600, 700, 800, sometimes 1,000, very, very high sugars. They get into an acidotic state, a severe acidotic state, and can be life-threatening depending on the concurrent illness, what has produced this DKA, and our capacity to get that ketoacidosis corrected. And then with type 2 diabetics, there's a condition called hyperglycemic hyperosmolar syndrome. So it's a high sugar syndrome, hyperglycemic, and hyperosmolar. So hyperosmolarity means they're highly concentrated. It's similar to DKA, but yet different. And we'll make that distinction. There's a comparison on table 46.7 for you to look at if you want to reference that. There's one condition that's not mentioned in your book that I will discuss here that's called euglycemic ketoacidosis, which is a condition in which characteristically type 2 diabetics develop a ketoacidosis and their sugar is within a relatively normal range. They don't have a big high sugar as in diabetic ketoacidosis. That's commonly with type 2 diabetics that are on the SGLT2 inhibitor medications. So that's one of the side effects of that medication. Although, as a footnote, we are seeing in the clinical environment manifestations of what we would call a euglycemic ketoacidosis in patients who are alcoholic or have severe starvation or anorexia. We're seeing some of those conditions show up there, but that's not the nature of our conversation, but that's just a footnote for you. So let's get to discussing some of this. So hypoglycemia is an abnormally low glucose, usually below 50 to 60, in which the patient may or may not have been on insulin or oral hypoglycemics, and possibly some physical activity. But the point is there's not enough carbohydrate to offset the glucose lowering agent that they're taking, whether it's insulin or an oral anti-diabetic medication. So that can be quite challenging. Now in a hospital and for testing purposes and all of that, we're going to use the parameter. I use 50 to 60 because that's what your book says. For our testing purposes, for the benefit of our exams, and hospitals use 70. Hospitals like to try to prevent a severe hypoglycemic event by addressing things when that number is a little bit higher. So 70 is going to be our number. Make a note of that. Notice the adrenergic symptoms: sweating, tremors, tachycardia, palpitations, nervousness, hunger. Those symptoms can be masked by beta blockers. So this is why earlier I mentioned with those oral anti-diabetic agents, we want to be cautious about having beta blockers on those patients because beta blockers will blunt these symptoms, specifically tachycardia and perhaps even tremors. And if they're not having tachycardia then they may not be having palpitations. So that can mask some of these symptoms. They may be more hypoglycemic than they realize. So that's why we want to be cautious with beta blockers in this population. Now, there are also some central nervous system symptoms. As the hypoglycemia worsens, patients develop symptoms such as confusion, perhaps lapses in memory, difficulty concentrating, and ultimately confusion, slurred speech, drowsiness, and if it gets severe enough, disorientation, seizures, and complete loss of consciousness and death. So this is, you may have heard a kind of colloquial cultural reference of insulin coma. That's what they're referring to here as severe hypoglycemia. So again, you notice that as these worsen, patients lose their capacity to act in their own benefit. So that's what makes this condition dangerous, particularly if they're not prepared or alone. So management of hypoglycemia. It's slightly different in the street or at home or out in the normal world than it is in the hospital. So there's a nuance to that treatment in the hospital. So the main thing here is we want to give 15 grams of fast-acting concentrated carbohydrate. And this could be 3 or 4 glucose tablets. There are some little packets I'm going to show you in a moment that basically have a measured dose of substance like cake icing that's a sublingually absorbed glucose, and it's measured 15 grams. Now, the important thing to remember here is that we don't just do the carbohydrate. That's great, but if we simply treat with a simple carbohydrate, what's going to happen is in about 15 minutes, we're going to see an increase in that sugar. But over the next 30 minutes to an hour, that sugar is going to plummet back to where it was before, because the insulin they have circulating is going to metabolize that 15 grams of insulin and not give us any benefit. So to that end, we want to also provide, in addition to, this is a great select all that apply question, in addition to the 15 grams of concentrated carbohydrate, we want to also give a snack that has a protein, a complex carbohydrate, and preferably a fat. So think about something like peanut butter and crackers with milk that has milk, which provides a fat as well as some complex sugars. There are complex carbohydrates in the cracker and protein in the peanut butter, in addition to the sugar that's in the peanut butter. So there's a lot of layers there to allow the sugar to enable the sugar to come up and stay up for a period of time afterwards. Granted, we may end up with a sugar that's 180, but we can fix that, and it's less life-threatening than is a glucose of 40. So we want to retest that blood glucose in 15 minutes and then treat, here again, if it's less than 70 milligrams per deciliter, or if even with a slightly higher but more pronounced symptoms. So if they're still tachycardic, confused, that sort of thing, then we're going to treat again. So we're going to test again in another 15 minutes after that, and then we can slowly begin to see if our sugar is stabilizing. So, short answer, if the sugar is less than 70, we're going to give 15 grams of concentrated carbohydrates. That could be glucose tablets, 4 to 6 ounces of juice, not diet soda. That's defeating the purpose. Juice or soda, possibly even with a sugar packet dissolved in it. So, simple sugar, protein, complex carbohydrate, fat, retest in 15 minutes. So lock that down. These are examples of the glucose packets I was telling you about. These are great things that patients can purchase and stick in their backpack or purse or some kind of bag that they carry. These things, patient does not have to swallow these. These are what I mentioned that can be placed under the tongue and absorbed that way. In the hospital, we have two substances that we can administer in this context, and that's going to depend on your institution and their protocol for hypoglycemia. And they are IM glucagon, which IM glucagon provides a longer acting action for the production of sugar. It stimulates the liver to do its gluconeogenesis and fatty acid metabolism to produce sugars. Now, here's the catch there. You say, well, wait a minute, we've talked about how that's bad. Yes, in a condition such as diabetic ketoacidosis. In this case, the sugar's low, so we want the liver making sugar, and we can correct that with insulin later. Or you may also see in a hospital 25 to 50 mils of D50, 50% dextrose. Basically, it's the most concentrated dextrose or sugar we can give in an IV solution. And again, you're going to recheck in 15 minutes and then check again in another 15, and then possibly move to every 30 minutes or hourly until the glucose is stabilized. That's for hypoglycemia. For hypoglycemia, we want to give sugar, complex carbohydrate, protein, and fat. Now, another complication is diabetic ketoacidosis, or DKA. I'm going to discuss this here. In class, we're going to have a fuller exercise where we present this and talk it through. So there's just not a convenient way to do that with a chalkboard here in my office. So basically, in diabetic ketoacidosis, what you have is you have a patient who is attempting to function in the absence of insulin, or perhaps a better way to say that is their insulin is insufficient in proportionate to the carbohydrates that they have in their bloodstream. So that is producing this state where they're producing ketones as a result of fatty acid metabolism, and the result of that ketone production creates an acidosis. In this case, this is a metabolic acidosis, and we will talk through what this looks like. It's a metabolic acidosis as a result of the liver doing the thing it does in the absence of insulin, and that is fatty acid metabolism, which is also called gluconeogenesis. So it's taking these fatty acids, breaking them down, and making carbohydrates. Part of the byproduct of that are these ketones and extra hydrogen molecules, which produce the acidosis. So the clinical features of this is their sugars are going to be very, very high. So typically, 600, 700 to 1,000, big range for sugars, very high. They'll also be intracellularly dehydrated. What's interesting about that is they look like they're making a lot of urine. Their urine, there's going to be a lot of it. It's going to be dilute, and they're going to be peeing a lot. However, within the cells themselves are dehydrated, and we'll again discuss that and blow that up in class. The result of this is that puts them in an acidotic state. They use up their immediate buffers, attempting to manage the ketones and the extra hydrogens, and then those become depleted. So bicarbonate, hydrochloride, or chloride become absorbed, become used up, and deficient, which then causes them to attempt to compensate from a respiratory standpoint, which means they're blowing off CO2 in an attempt to compensate. That makes them tachypnic. And there you have it. You have their attempt to compensate is not meeting their demand, and they end up in this acidotic state. And again, some of this is referenced on table 46 too. One of the key things to remember here is People sometimes make the false assumption that patients who are in DKA are not taking care of themselves. And that's actually not the case sometimes. There are occasions where that happens, but there are times when patients who have diabetes get sick. Diabetic patients get the flu, diabetic patients get COVID-19, they get strep infections, they get UTIs. Those infections, any kind of insult to the body, can put a demand on the body that makes their carbohydrate supply higher than their insulin supply. And remember, this commonly happens with this is what happens with type 1 diabetics. And that then they're not making insulin, so they have no resources upon which to fall back. This makes their condition further complicated, their illness. They're nauseous, they're throwing up, they don't feel like eating, they're perhaps becoming dehydrated because they're not drinking, because they're nauseous. If they're not continuing to take insulin, they're going to be thrown into fatty acid metabolism, gluconeogenesis, and this problem is going to take off like a spiral. For that reason, they need to have sick day rules, and those will be rules they establish with their physician over how often they take their sugar, how much insulin they take, and how they manage with perhaps Gatorade or Pedialyte or some other substance that has some carbohydrates to meet their need and keep them safe and able to take their insulin to prevent them from going into ketoacidosis. This becomes a very challenging disease to manage, both in the well state and in an ill state. So as I mentioned before, glucose levels, this is greater than 300 to 1,000. Actually, they're going to be much higher than that. The severity of the DKA is not determined by the blood glucose level. Remember, I've said this over and over again. The glucose is a symptom of these conditions of insulin. It's not the problem. The ketoacidosis is what determines the severity, and that's assessed by the anion gap, our old friend, the anion gap. And we're going to discuss that, and we'll go over that and through that in class, hopefully pretty thoroughly. But their degree of ketoacidosis is what determines the severity of their illness, along with whatever concurrent condition is producing that. So if it's pneumonia or the flu, the severity of that pneumonia, the severity of that flu manifestation also contributes to the severity of this condition. I've already mentioned that this is a result of ketones in the blood and urine. That's what produces that fruity smell in the patient themselves, as well as their urine output. And the electrolytes are going to vary depending on where they are in this process. And that's one of those things we will walk through in detail in class. So how are we going to treat this? There are two things that are the key treatment for this problem. We talk about treating the problem, managing the symptoms. The real problem here is the lack of insulin. That's part of the problem, emphasis on part of the problem. If you will recall, I mentioned earlier in a previous lecture that these high sugar states pull fluid into the vascular space. In these patients, it draws fluid from that splanchnic and mesenteric bed into the venous return system. So the inferior vena cava specifically, but you could also say the superior vena cava. It draws blood from the periphery from the gut into the central circulation, which means those organs tend to not be perfused as well. So that can produce organ damage if left untreated or if not treated quickly. So what I'm saying is that rehydration becomes an essential part of the treatment. Yes, it's managing the symptoms of discomfort, but it's not about managing the symptoms. It's about treating that cellular dehydration that we were talking about earlier, because that's the second problem here. The first being the lack of insulin, the second being cellular dehydration. So the key here is we've got to shift them back to carbohydrate metabolism from fatty acid metabolism. And what's going to do that? Insulin. Insulin does that. So As a process of rehydrating and getting insulin on board and shifting back to carbohydrate metabolism, then we're going to be in the position where we're going to reverse the acidosis and restore electrolyte balance. That means we're going to eventually bring this elevated potassium that you're going to see in these patients, we're going to bring that down because we're going to get potassium shifted back into the cell. We're going to move hydrogens out of the cell and bind them with bicarbonate or chloride. We're going to buffer them. And that's going to help return our electrolyte balance and eliminate some of the risks of arrhythmias. During this process, we've got to monitor blood glucose. We've got to monitor kidney function because we can lose we can lose nephrons as a part of this process. So we've got to monitor kidney function in addition to urinary output. This is one of those instances where urine output alone is not an adequate assessment of kidney function. So they're going to have a lot of urine output. We've got to measure BUN creatinine to know how those kidneys are actually functioning and filtering. EKG monitoring is going to be very important because these patients are going to be prone to arrhythmias from the changes in electrolytes, specifically potassium. We definitely are going to continue to assess vital signs and lung sounds. We are observing for fluid overload. We're going to be putting a lot of fluid into these people because they're going to need it. But there may be patients we have to be more cautious about our fluid replacement behaviors. So we'll see where that goes, but we have to keep assessing them as we do. So here's a question for you just to toss out there. What category of insulin is rapid acting? And that would be Humalog. Humalog is the rapid acting. Humalog R is short acting, and Aspart is also considered rapid acting. But then Humulin N is intermittent and Glargine is very long acting. Now, one condition that's not mentioned in your book that I want to provide you some notes on is this condition called euglycemic ketoacidosis. So this condition is similar to diabetic ketoacidosis. However, the patient's glucose is still in a relatively normal range. Now, I'm not saying their sugars will be normal. They may be, but they may also be, 180, 200. The point is they're not severely hyperglycemic like they are in HHS and DKA. These conditions typically manifest with our type 2 diabetics who are taking the SGLT2 inhibitors. That class of medications are specifically prone to causing euglycemic ketoacidosis in these patients. As before with other ketoacidotic states, this can be facilitated by some concurrent illness such as pneumonia, UTI, flu, something like that. What is the issue here is that they have a carbohydrate deficiency in relationship to the insulin that's present, or an insulin carbohydrate deficit. So they have decreased insulin and increased glucagon, so they still have insulin to manage and prevent them from getting into this big ketoacidosis. However, they have more carbohydrates than they can proportionately handle compared to the insulin that they have. And that lack of insulin then allows the evolution of the ketoacidosis because they are, granted, their sugars aren't high, they aren't astronomical, but they are coming from the liver. That's where this carbohydrate deficit comes in, because you're like, wait a minute, this sounds like you're talking out of both sides of your mouth. Let me try to explain it this way. The patient has insulin that they're producing. It may not be a whole lot, but as we've said before, type 2 diabetics are producing insulin. They evolve a condition, whether it's an illness or just taking this medication, in which they lower their carbohydrates, not to a hypoglycemic state, but enough so that the liver then says, we should produce some sugars from fatty acid metabolism. Remember, that's where the ketoacidosis comes from. Those ketones are the acids along with hydrogen that contribute to the ketoacidosis. So glucagon is what's in this low carbohydrate state. Glucagon gets signaled to fire. So glucagon signals the liver to metabolize fats to make sugar. Now their sugars, again, aren't astronomical, but they're more from fatty acid metabolism than they are from food consumption. This produces the increased ketones, which produces the ketoacidosis. So it looks very similar to a ketoacidosis. They will have a high anion gap, and we may have to treat them with insulin in order to correct this situation, in addition to correcting whatever illness or problem has precipitated this event. So the treatment looks the same. The dosage of insulin infusion may be different. Now, with hyperglycemic hyperosmolar syndrome, this is slightly different because in this case, the patients do not develop ketosis, or if they do, it's minimal, because they never fully shift into ketoacidosis metabolism. Because why? Because these patients are, again, the type 2 diabetics who are still producing insulin. This is caused by a lack of sufficient insulin. That's important because it tells you there's not enough insulin, but it also tells you that there is insulin, which is what prevents the ketoacidosis. So hyperglycemia is one of the characteristics here. These patients will have 400, 500, 600 blood sugars, and that high glucose will cause an osmotic glycemic diuresis, just like it does in other diabetic patients in DKA, and is going to result in a lot of water and electrolytes. They're going to be peeing a lot. They will eventually develop a hypernatremia and increased osmolarity because of all of this urinating that they're doing. And what this is going to show up as in these population is they're going to be hypotensive, they're going to be dehydrated, again, intracellularly, same principles because it's the same glycemic diuresis, and variable neurologic symptoms, generally because of cerebral edema. Some of this fluid gets stolen from the cerebral blood flow in addition to the abdominal blood flow like we've discussed. Now, these patients do have a high mortality rate dependent upon how aggressively we treat these conditions. So in this case, it's actually, if we're too aggressive with fluid replacement, we can create cerebral edema and cause problems. Like DKA and euglycemic ketoacidosis, it's commonly initiated by an infection. An infection sets off a cycle that makes a feedback loop that makes it difficult to manage these sugars. And this hyperosmolar hyperglycemia causes a basically disproportionate. We've got too many sugars for the insulin we have. But we do have insulin, so we don't get ketoacidosis like we were just discussing. We've just mentioned the osmotic diuresis, lots of water, hypernatremia. Now you will remember this next thing from something I talked about earlier on in class, these idiogenic osmoles, which are little osmolar chemicals in the brain that do not cross the blood-brain barrier. What that does is helps preserve cerebral function as long as possible. So when the rest of the body is dehydrated to the point of hypotension and tachycardia, the patient may not have yet developed neurological symptoms, but as that persists, ultimately the brain is going to experience a hypernatremia in addition to the presence of these idiogenic osmoles. So the brain is going to be hypertonic. If we start replacing fluid too quickly and correct this too quickly, then what's going to happen is a great deal of fluid is going to shift across the blood-brain barrier because of this hypertonic extracellular fluid in the brain as a result of these idiogenic osmoles. So the brain is then going to hold on to more fluid, draw more fluid in, and create cerebral edema, which can then produce severe neurological complications resulting in ultimately death if we're too aggressive with fluid replacement in this population. So this slide right here gives you an overview of the differences in lab values between DKA, diabetic ketoacidosis, and hyperosmotic hyperglycemic hyperosmolar syndrome. You see the range here, and sometimes actually these sugars will go higher than 250 to 600, but you can see that sometimes even the HHS can get up in the 1200 range, which is much higher. DKA, their sodium's going to look a little lower than the HHS patients. Notice that these things appear normal. The creatinine only moderately increased. Notice the osmolarity difference between these two. That's noteworthy, along with this change in plasma ketones. Why do they not have a really negligible change in ketones? Because these patients, HHS patients, are still producing insulin. Bicarbonates is usually going to be normal, maybe slightly decreased, not really low like in the DKA patient. pH is going to be normal or just maybe slightly acidotic. Their PCO2 is going to be normal, where it's going to be lower in the DKA population. And notice this. The anion gap here is elevated in the DKA patient, and then the anion gap is most commonly normal in the HHS patient. So pretty distinctive differences there. So how are we going to treat HHS? Rehydration very, very cautiously, and we're going to gradually correct the glucose. We don't want to, with the rehydration and rapidly correcting glucose like we might a little more aggressively with DKA, we are going to perpetuate or run the risk of cerebral edema. So we're going to be a little slower with these patients. We're going to, again, like before, monitor fluid and electrolyte status. And the way we prevent this should sound familiar now: blood glucose self-monitoring, diagnosis and management of diabetes, and assessing and promoting the self-care management skills, that education piece that we were talking about earlier. So this kind of gives you the overview and discussion of the major adverse events associated with diabetes and how we manage them. And again, we'll supplement some of this with some material in class. And thanks for listening.